services for the health. Susan, I'm the director of system development club.
Jim Weber, community education liaison for the Office of State Staff.
Veronica Dietz, director of crisis services here at the health department.
Robert Wack, deputy health officer.
Liz Yancey, Liz, I don't even know my own name. Deputy health officer for operations. Oh, my bad.
Ed Singer, manager of the local management board, Carroll County.
I'm Corey Hardinger, government and government.
I'll go across my screen. First one up is Valerie. Well,
Valerie Hawkins, Carroll County Department of Public Safety.
Thank you. Now it's Jennifer.
Hi, sorry, I was having trouble on my cell phone, so I switched over. Jennifer Mafucci, I'm with the Division of Parole and Probation.
Beth.
Community, which Beth?
Sorry, Beth.
Y'all said Beth, right?
Yeah, we heard you.
Okay. I'm with Maryland ROPTA and Maryland Treatment Centers.
Okay. Tiffany.
Regional Director of Crisis for the affiliated Sante Group and Director of Carroll County Mobile Crisis.
Celine.
Hello, Celine Steckel, Director of Citizen Services with Carroll County Government.
I got Charles.
Hello, I'm the chief psychologist at Springfield Hospital Center, also the director for the Addiction Recovery Services.
Thank you. Lauren.
Hi, Lauren McCarthy, Executive Director for Mountain Manor, Maryland Treatment Centers.
I need three more. Both names begin with S's, but I don't know. I can't see the screen, sorry. Kathy something.
You have Sam Bowman,
Sam.
Oh, there we go.
Susan.
Susan Krebs, interested citizen.
Thank you. Avery.
Hi, everyone. Avery Meyer from Maryland's Office of Overdose Response.
Thank you. I see Sam says he's muted. I don't know that we can help you with that. I believe the minutes are now correct. We had a little bit of a glitch with, if you have many sets of them, they might have the wrong people on the attendees.
Avery's here.
No,
Avery.
you introduced yourself.
Oh, she did. I missed it. Okay.
So I need a motion to accept the minutes, or if there's any changes to the minutes. Motion to accept. Second. Thank you. Liz and Tim. I'm having him. I've already done it. We all have to be organized today. It's my first day back from vacation. I apologize. All right. I do not see Commissioner Guerin here, so I'm gonna assume there's no updates unless you have something.
I just want to share that on Thursday, the health department will be doing 2 proclamations at County Commissioner's office, which is tomorrow. One for suicide and one for recovery month. So if anybody's interested in attending, please join us.
And I don't see Brant. Do we have a report from Brant?
I think Amy's going to cover some of that information in her presentation.
Okay. Avery, you're sliding up on the agenda.
Sounds good. Yeah, a couple updates to give the group. So our competitive grant awards went out a few months ago. We do have a grant award summary that we publish on our website. I'll drop the link in the chat, but that way you can take a peek and see where grant funds went this year. Next update is for the opioid restitution fund, that state discretionary pot. There was a request for options earlier this summer. Those closed at the end of July. And currently those grants are being reviewed, emphasizing to folks that BHA under MDH is doing that grant review process, not our office, but as we hear any updates on when they expect to get award letters out to folks, we will certainly update people. Also through MDH, we want to highlight that there is a new overdose data dashboard. So that what the dashboard that has been on our website is now gone, and instead we are unified and using the one that is on the MDH website, which I can also drop the link for that chat. But I encourage folks to just kind of take a peek, poke around in there. There's some different functions than we had on our dashboard prior. You can get all the way down to zip code level data if the numbers are high enough for them to not be suppressed. There's some non-fatal metrics in there. So overall, some new data points that folks will be able to access, and I know that they're continuing to improve that. So I encourage folks to look at that. Another thing I'll share, we had the program, what did we call it? We call it a bunch of different things. The program inventory survey that our OPTs fill out. That used to be quarterly, that we've moved to biannual. That first one was due at the beginning of July. So we have a report that's kind of summarizing what we found from that survey. The survey was changed this year. We took away some programs, added some new programs, restructured it. So this is the first report those changes. And then lastly, I will highlight for folks, Happy Recovery Month. Special Secretary Keller is making her way about the state to do some site visits in every county across the state over the coming weeks. Less formal than our town halls, really just getting back out into the communities and going to see treatment centers or organizations that are working in the recovery space that we did not get to see when we were there for our town hall. She will be in Carroll County on pulling up the calendar, September 18th. Yes, so she is looking forward to that. But that's all that I have on our end. Happy to take any questions if folks have any.
I think we're following up. I think Dr. Wack followed up on a conversation we had with a vendor who applied for one of the more grant opportunities, and they had an issue with their SSTAT, but they were a nonprofit, so they didn't understand how they were not in good standing. And we followed up with them, and that's filing their 990 form. So I don't know if some more clarification on the website could help with that, because the nonprofits don't understand. They don't think they have a nonprofit status to be in good standing with the state, but apparently their 990 forms can put them in bad standing. So a little bit more clarification might help, but we did have that question from, I think, 2 providers that were not in good standing.
Okay, I will double check with Khalil on that, because frankly, anything related to good standing and finances goes right over my head. So I'll flag that for Khalil and see if we can get some clarification there. Thank you.
That's fine. And then on to the local behavioral health reports. Kathy and her team have some information to share with us.
All right, Amy, you gotta come present this.
Please.
Sorry, give me a second. Okay. I don't know what that means.
Can everybody see that? So before we talk about Vibrate, we're going to talk about the SIM, the sequential intercept mapping, which is on the agenda twice. We apologize. Veronica, do you want to share a little bit about that?
Sure. For those who don't know what the SIM stands for, SIM stands for Sequential Intercept Model. The idea is that it was a concept created in the early 2000s through the Samson Gaines Institute, really looking at the continuum, the criminal justice continuum, and how individuals with behavioral health issues will filter in and out of the criminal justice system. So they look at that system at what they call intercepts. They start at 0, which is community-based, and go to 5, which is a person who has gone through the justice system. and is at a full information level and returning to the community. And so what we're really looking to do is identify programs, resources, services that are eligible for individuals with behavioral health issues at various intercepts, and ways that we can divert or deflect individuals out of those intercepts and into community-based services and provide stability for those individuals. So in March of this past year, we hosted our sequential intercept model mapping workshop. I think we hosted 50 plus people from each intercept, different partners and stakeholders at the various intercepts at the Public Safety Training Center. We met the entire day, everybody from judges to community providers. And we sat and we just kind of talked a little bit about what does Carroll County have, where are the resources, and where are the gaps. And at the end of that day, we identified 3 of our priorities that we would like to address. That included establishing mental health court in Carroll County, working to establish a crisis centers, a place where individuals in crisis can go and receive support and services. And there was also, the group felt a need to look at expanding services to evenings and weekends. Oftentimes, crises happen and many providers are not open or available on nights and weekends, which ends up being that the hospital becomes our go-to and law enforcement becomes our primary partner doing the work. And so if we can find ways to expand services and access to evenings and weekends, we really can support individuals with serious and persistent mental health issues and substance use disorders more effectively. We did meet with the team at the governor's office probably about 2 weeks ago. They are in the final stages of putting together our report. We're really excited to see that. That should go up. The governor's office does host a sequential intercept model mapping dashboard. They currently do have Charles, Cecil, Prince George's, and one other county has had their sequential model mapping done, and their reports are live and online, so you can go and see what other counties have done. Ours will be there soon, and once we get that back, our goal is to utilize a pre-established diversion work group. It is a subcommittee of our Behavioral Health Advisory Council to serve as kind of a board for moving some of these initiatives forward. How do we establish a mental health board? What partners need to get at the table? What conversations do we need to have? How can we continue to do this work in the community, partnering, which is really our best effort. So that's the plan. As soon as we do have that report, we will let everybody know. We'll share that out. But our goal is to really start to establish the diversion work group as the board that will move our priorities forward.
Okay. Any questions for Veronica from anyone? We'll be sure to send the link out for the dashboard prior to the report going live so that everybody can access that from, and if you have difficulty, you can just let us know. So the next thing up is
Kathy, are you folks still there? I think the audio went out for those of us online.
It looks like they left the meeting. Like they accidentally
It said
exited out
Teresa
of
left the meeting.
There we go.
Oh, yeah.
They're back.
Sorry about that. I'm sorry, what was next?
988 Vibrant.
Oh, the Vibrant, okay.
So we monthly get a report for the statewide 988 service, and how many calls are being received, how many are managed on the phone for services, the call rate trends. So all of these, the last 2 reports are linked to the invite for today, and you can see that the access is increasing for where people are beginning to recognize the need to call 988 instead of calling 911. And that's really what we want to try to impress upon people. If you're having a mental health crisis, that 988 is the call number to be called. Unfortunately for the people on the phone or on the link, I don't have 988 stuff for you but you can reach out to me or Marie to get some 988 stuff and then stop by and pick it up. We don't deliver, but you're welcome to come get it. We have lots of 988 materials. There are some here for anybody that's in the room as well. So, but you can scroll down a little bit, Amy, and show them. So it's the, yeah.
They should still see us
The call
scrolling.
rate trends seems to be kind of averaging out a little bit for the months. The average speed to answering the phones has decreased. That means the persons on the other end of the phone that are giving the service are a little quicker to respond and close the calls. The chat volume has increased. Chat's available for 988 as well. And the texting is also decreasing at this point for the, what month is this? May?
June, May, yeah, May.
Yeah. Hold on. Right there. So these are the jurisdictions that have the call centers. As you can see, the numbers are varied. I'm not really sure where every mind is, but they seems to be having the most number of calls from what I can see from here.
Where would calls from Carroll County go?
Grassroots or is it grassroots for all the
Yes.
yeah. So, and then Frederick County, which is our neighboring county, has their own call center at their mental health association. Hold in. And then there we are with Carroll County's data. It looks like 739, if I'm reading that correctly, since inception. So.
How long has this been in place?
90 days.
Yeah.
Yeah.
I was just wondering when the data started.
I don't know. I don't remember either, but we're just now getting data. So I only have like the last quarter, April, May, June's data.
I would assume July of 23, is it, or 22? July of 22 is when 988 went live.
Yeah.
But
I don't think Vibrant was in the call centers.
Yeah.
So,
It looks like from that maybe they're getting a call a day from Carroll.
yeah. But by population, we're a kind of equivalent to a lot of the counties on the lower end of the trend. And then calls last month. This is May.
I think this is June now.
What was the yellow? I'm sorry.
Oh, that's okay.
Calls per county, all time, from the beginning.
I think the data, I remember starting to see the data last year, from G-Breaks, which renamed.
Yeah, but it wasn't the
Central
Vibrant
Maryland.
stuff. Yeah. They were G-Breaks was having difficulty pulling out the county stuff. We couldn't get the local numbers, but this gives us the local information, So you can look for these on a regular basis. We will be sending these out so everybody can get a perspective on what's going on with 988. And there is a discussion right now that 988 will be, 911 will be moving through 988 for behavioral health calls in the next few years. That's going to be a process where if you call, they get a call at 911 for behavior health. There's a protocol that's been developed. Actually, Nebraska has already moved this way, that the dispatchers automatically move those calls to 988, where the experienced staff are to be able to handle the calls and have the resources available so that it doesn't bog down the 911 system. But you know, what we want to do is try to impress upon everybody that if you're having a crisis, that 988 is the way to go now. So if we can get 988 in all 175,000 people's minds, that's where you call for behavioral health crisis or suicide ideations, that we can get ahead of that ballgame. So
we actually had an update today too at one of our meetings that for youth under the age of 12, for the whole state, there were 70 calls in July, and that 70% of the calls in total are handled are able to be handled by the 988 operator. And only 30% are actually being diverted for resources, referrals, and dispatch if needed.
Or EMS.
That shows you the call center is really working. That's great.
I want to just follow up on that. This is Susan Krebs. Are we getting any data back from the recipient of the calls of what's the final result and the resolutions of the calls in 988?
That's page 3.
Okay.
Are they getting satisfactory diversion or answers, or what? How are we measuring that?
We're trying to find the data.
Because that was one of the big concerns we had when we put it in place a number of years ago.
Yeah, there is another set of data that does give us whether the calls were resolved on the phone or whether they were resolved in the EMS response. And so I can have Teresa send that data out as well.
That would be good. And then we want to find out, from the person at the, whether it's resolved for that call or resolved, what's happening. Are they recurring the call? Following up on, I'm not sure if there is any kind of follow-up, but figuring out what's happening with the call. And is it handled in Carroll County? Is it being handled by grassroots? Are they being diverted somewhere else? I'm not sure if there's data on all of that, but that's the end result.
The data in Vibrant gets that far down, but I can certainly ask the questions.
Okay. All right, because that's the end result. We want to make sure we're getting good quality services to those people in this new method, which I think is a good way of putting it.
Well, I think the services are being given to the individuals calling. It's what we want to see is the increase in the call volume for 988 and a decrease in the 911 calls, so that they're actually getting linked to services or it's being handled on the phone. The crisis counselors are experienced and have a lot of training that's been given to them over this last 2 to 3 years. So they're handling a lot of the calls on, as Marie just said about the adolescents, it's happening with the adults as well.
Good. All right. Thank you.
I thought I saw Sharon McLaren jump on the call, and I don't know if she has any feedback on whether or not we're seeing an impact on the emergency room visits.
Sharon's here, and I did look last week actually at emergency department visits, and it looks like they are decreasing some. We are validating I got it out of Chris, so I'm assuming the data is good, but I just want to validate it with our internal team.
And that's the overall goal. We were trying to utilize the emergency room for what it's there for, your health services for what they're there for, and the crisis centers, which are going to be regional eventually, when they get it all worked out, for what their purpose is. So we want to point the person to the most appropriate service to get their needs met. So, but ultimately, hopefully, impacting the emergency rooms that get used as makeshift site minutes.
And they're getting people the services they need.
Correct.
And that people don't have to suffer, that they can actually reach out and get assistance.
So
That's
we're
the
not
biggest
boarding
thing.
somebody in the emergency room for 21 days while we're trying to find a bed for them.
Right.
It's a complex issue. Getting all of this lined up. You all have the next.
Yeah, Marie has the next.
Oh, so to piggyback on the 988, what I know Sue brought up GBRICS. So GBRICS is now called Central Maryland Crisis Response System. So that was actually a 5-year grant that started in 2019 to encompass 4 counties: Carroll County, Howard County, Baltimore City, and Baltimore County. Well, because it's a 5-year grant, it's slated to end within the next year. So in looking at sustainability, I talked with the Route Systems of Baltimore, who is the vendor for the GBRICS. I still call it GBRICS, I'm sorry. And for their sustainability, what they're thinking is that they're hoping that the counties that are involved in the pilot would continue on with them and still be considered part of the region as far as marketing is concerned, and that the 988 Trust Fund would continue to fund the service for that response. And that when crisis regs come out, that some of the stuff that they're doing will be reimbursable through Medicaid. So
each county would still resolve their crisis services within the county. We would make sure that the 988 centers had those resources and that information and were educated on it. People would continue to call 988, get referred to resources, or get referred to EMS if needed. And each county would continue to monitor. Which sounds like from the beginning, what we were thinking was
Yeah.
gonna happen.
Yeah.
With sustainability for this model.
They
So-
still want to market together though, as the central region.
Well, I think for us, it doesn't make sense for us to set up a whole separate 988 call center.
Absolutely.
We would have to be with somebody else regionally, and we're already there, and they already know the resources, so I guess it would make sense to stay
And
that way.
Especially with the limited amount of overnight calls. So
Correct.
they handle that for us, which is great.
Tiffany, do you have anything to add to that conversation?
No, I just know that, so they are talking about the 988 trust fund, hopefully being part of the sustainability plan, and then hopefully local partners will continue to provide some funding. And then where we will be part of the reimbursable services, once the crisis regs are, I mean, I know they're finalized now, but once everybody comes, all the applications and everything are approved, we're in that process right now. We've had our applications submitted to Medicaid. So that's where we are in regards to that.
Any other questions? And Amy, you're up next.
Okay. Or overdose. Okay. So Brooke is going to come up with me. And Brooke, would you mind bringing the papers that I put right there? Let me get this set first. Still loading. It's going to take a second. There we go. Okay, so if you're joining virtually, just let us know if any of this is not coming through for you. But Brooke and I are going to do a very brief presentation around just an update on overdoses. The data that we're going to give you, sorry, thank you so much, is from 3 sources. One is from the Maryland Department of Health Vital Statistics Administration. One is from the Carroll County Sheriff's Office. And the other is from Carroll Hospital, and we appreciate their data. So we're going to start off with vital statistics. I realize this is a lot. So while you're kind of looking at this and absorbing this, I'm going to read you a couple notes about the vital statistics data just to kind of keep in mind. So the methodology for reporting this data in Maryland, the data on any drug-related intoxication death was developed by Vital Statistics. In partnership with the Maryland Department of Health and the Office of the Chief Medical Examiner and the Maryland Poison Control Center. You're going to notice that we really wanted to give like a trend over time snapshot of all different fatal overdoses. And it starts in 2012. Please note that the 2022 data is preliminary. Based on as of October 10th, 2023, and it may change as it's finalized through Vital Statistics. And you'll see that some of the different drug-related intoxication deaths are not being reported on because it is preliminary. So I just put an NR for not reported. But for the others, you're able to see kind of a comprehensive look. A couple of other different things to note. Unintentional drug and alcohol-related intoxication deaths. What that means is deaths resulting from recent ingestion or exposure to alcohol or other types of drugs, including heroin, prescription opioids, benzos, cocaine, the different sort of drugs that you see here. Because an intoxication death may involve more than one substance, you'll see that the totals are not going to sum to the total number of deaths, if that makes sense. Because one person may have had multiple different substances, that's going to be counted multiple different times in the individual substance, but only once in the total number of deaths. And the full report, which I'm hoping that we're getting, the last annual report we got from the OCME, which is so helpful because they do a trend analysis for us, is actually from 2021. So I think COVID probably really slowed down that process. And we're still, Amy's going to talk about preliminary data as well. We're still really waiting on final data from that. What we do have is a preliminary annual report from 2022, and we also have up to Q3 quarterly reports. But again, these are preliminary, so they might change. But it does give you a sense that of what we're sort of looking at over the past decade in Carroll County. One last thing I wanted to say before we move on from here. The other thing that's helpful in the full report is they break down the proportion of cases where death from a drug did or did not also involve an opioid. So in other words, they were helpful when fentanyl started coming out and we saw cocaine-related deaths increasing in their analysis to help us understand that this is very likely the presence of fentanyl in the cocaine, not necessarily the cocaine itself, which of course can be deadly. So any questions about the vital statistics data?
Curious,
Sure.
I mean, I know we've always seen it. We, didn't really see any trends. It kind of bouncing up and down for a while. 29 is a significant difference. Where are we this year?
We're going to get to that.
Okay.
That's next.
Okay.
Amy, are we gonna get this?
Sure.
You already have it, you should have it.
We do.
Oh, yeah, it's in the appointment for today.
Okay.
The calendar.
I saw the suicide one. I don't know if I saw that.
I'm not sure this one's been sent out yet, but it will be.
Okay.
Yes, this one wasn't included. I read it.
Oh, I'm sorry.
I was walking down the
We'll get
it.
Okay.
She missed me by a minute. Okay. And so I will add a source to this. You can find this on the Maryland Department of Health website, the vital statistics, and they break it down into annual reports, preliminary reports, quarterly reports. I really encourage you to go back and read the annual report that we do have from 2021, the full annual report, because it's just a wealth of knowledge and analyses and information about the different drug trends.
Hi, this is Susan Krebs. I just want to, if Avery's still on there, Avery, I'd like to just suggest that maybe you bring to the attention of the administration that these reports are 3 years old, and it's really hard for groups like ours to look at data that's 3 years old and figure out where we need to be. And COVID is over, and we got to figure out why the data is still so old. Because once the medical examiner does the autopsy, they should have the reports. It's just the compilation of the data. So it's really hard. I mean, I know in other areas we have the same problem of the collection of data, but it's not very useful when it's 3 years old. So just if that could be taken back of how many people actually look at this data and make decisions on it, needs to be more up to date. So
Yeah.
it's just an observation.
No, absolutely. I hear you, Susan. We hear this all the time. It's really frustrating that we have different timelines with different data sources and the numbers mismatch. It's a big problem. We'll flag it again for vital statistics through MDH. I also always encourage folks that data dashboard isn't perfect, but it has the most current data that we will have. There's still preliminary things that have to be considered, but if you're looking for a proxy of more recent data, definitely take a peek at that dashboard. But your point is well heard.
A lot of times, like when I went down and visited OSME, the fact that they know that people are actually looking at it and using it maybe sometimes gives them a valid reason to get it done. It is not just sitting on a shelf somewhere. It's being used.
Sure.
Thank you.
Yeah, of course.
And that's a really good segue to our next data set. We're very reliant on our sheriff's office, and we appreciate them collating all the data for us. Brooke is going to present this. Let me grab a tissue.
So this is total overdose cases, which have decreased from 2019 to 2023. The 2023 data shows an 8.5% decrease in total overdoses when compared to 2022. So we can see that we are trending down. Okay. And then this chart shows a 5-year comparison of fatalities from 2020 to 2024. What we have so far for 2024 broken down by month. We don't yet have August data. However, there is a clear trend of fatalities going down by year. And also you can see that there's less each month compared to months in previous years. Give everyone a second to take a look at that. All right, and this is our last sheriff's office data, and this is 2024 year to date since August 1st. We don't yet have the most recent for what would have been August and September. Hopefully we'll receive that soon. There have been a total of 117 overdoses and 10 fatalities. 1% of total cases were suicides and 38% suicide attempts. The most frequently used method of overdose is prescription medications, with fentanyl closely behind. And Westminster makes up 30% of all overdoses, and the age range of 35 to 44 make up the largest age bracket. Are there any questions on sheriff's data?
Is that calendar year to date or is that rolling calendar year to date?
This is rolling calendar.
Is it rolling calendar?
Yeah, January to now, so just, yeah.
To August, yeah. All right, so now we're going to get into Carroll Hospital's data. So this chart is showing the visits with alcohol-related diagnosis from August 2023 to July 2024. There has been a decline from March to July. And then also I wanted to note that these do indicate standalone visits, so they could be the same person coming into multiple visits. We don't have that information. Right. And then this is a continuation of Carroll Hospital's alcohol-related diagnosis, but this is by age from August 2023 to July 2024. There has been an increase in the 60 to 69 age group, and there was also a steady increase for ages 40 to 49, but it does seem to be beginning to decline. Any questions on any of that information?
And all this will go out.
All right.
Okay. We ready to switch to?
Yeah. Oh, okay. You guys are still.
I have very data dense slides. I just want to make sure I can see them. See if this is too tiny.
Wait till it comes up, and then you have to go to that one. Okay, so we go in slideshow. And it should be just
Okay, yes. So I was asked to present on some suicide stats today. So before we really dive into the Carroll County data, I just wanted to take a minute to see how we compare to the state and the country. So these are rates per 100,000 for 2021. See, the United States rate is 14.1. Maryland is much lower at 9.7. And actually, Maryland had the fourth lowest rate in the entire country. So the good news for Carroll, we're at 13.1. We are a little bit lower than the country's rate. However, we are, and we consistently are higher than the state rate. And that has been the case for at least the last 10 years. Okay, so here is the data that we'll be discussing. This is suicide fatalities, Carroll County residents by year and by method. This data comes from Maryland Vital Statistics Administration. We'll be looking at 2012 through 2023, and just note both 2022 and 2023 are still considered preliminary at this time. I don't expect them to change very much, but they might change a little bit. So looking at the totals on the bottom row, we had a grand total of 256 fatalities during this time frame, usually about 20 something per year. Looks like it ranges from about 15 to 30. I've also divided out between method into three major method categories. We've got firearms, suffocation, which is hanging, poisoning, which includes drug overdoses, but I did see a few carbon monoxide poisonings in there as well, but mostly drug overdoses.
And then we have the other category for all other methods. So here is that same data shown graphically. The top thicker line there is all methods combined. See no really clear trend, but maybe an overall decrease. We had a high of 30 in 2014 and a low of 15 last year. Again, not final data. The methods are broken out below. So most of them are by firearm. That's the dotted blue line. And we've got suffocation in orange. And the bottom line are the poisoning fatalities. Sure.
So when it's a poisoning from drugs, how do they know, an overdose? How do they know that is it by a note was left? Is it by the type of drug?
How do they know it was suicide?
Yeah.
Well, sometimes they don't. It's probably underreported. They really only rule it suicide, I think, if they have clear evidence. A lot of times these remain undetermined manner. So
if you look at our overdose data,
yeah,
you'll see it more clearly how many were suicides
Yeah.
because they lived
Mhm.
and they were in the suicide attempt. So we always know that our suicide data for poisoning by using a drug is underreported because people don't even know.
Right.
So some of those fatalities that happened, most likely suicides, but they didn't even know. So they don't get counted as a suicide, they count as our fatalities for overdoses. So that's our challenge when we look at that data, is trying to sift through that. So the non-fatals, people who survive, are the ones that help us to figure out what that average is, that percentage of people, and I'm sure it changes year to year.
Right.
Without that definitive note, or somebody saying they heard them saying these things and how they were going to do it, there's really, we
Is it a
know our
particular
suicide
drug?
rates and our overdose rates kind of need to move closer together.
Is it a predominant drug that is more used when it's going to be a surgery?
And just really quickly, I do have what Vital Statistics talks about, like how complex the investigations are. Just like you said, they said it can involve scene examination, review of witnesses, medical police reports, autopsy, toxicological analysis. So as much as possible to gather the information to determine, but they won't.
Yeah, we do have quite a few still left as undetermined, and they just are finalized as
The
undetermined.
overdose is from acetaminophen poisoning, which is usually a lot of times what people use is something over the counter. And they do the toxology. They'll say, oh, there was X amount that, clearly this could be suicide attempt because you actually feel bad for a little while, then you feel good, and then you feel bad and die. Very effective method if people do that research, to do that. So I guess by what drug they find also they may determine. With a drug of, also that's a drug of abuse, they might not be willing to say it was a suicide attempt because they were no drug user.
Yeah, that's what was.
And the sheriff's office report also lists
Yeah,
undetermined.
I see it on there, and I'm being curious about that.
Yeah, so good
Also-
question. And this analysis is just limited to those that they've ruled as suicides.
Yeah, I mean, as Tim, we've seen overdose with prescriptions, especially our younger population and our older population. Those that are like 60 and above have a tendency to use prescription medications more so than any other source of drugs for attempted suicide.
And then the cannabis adds fuel to the fire because people use the cannabis for medical purposes and it doesn't work the way they think it's going to work. So then they take their medication for their pain after they've taken 2 or 3 gummies for the pain, and then everything collides at the same time and they end up as an ER visit. If you look at a lot of the data from Colorado, you'll see that. Of the unintended overuse because they weren't getting the effect in the time they thought they should have, so they went ahead and took their prescription medications on top of.
Okay, so just to put some numbers and percentages to the methods, almost exactly half of our suicide fatalities were by firearm, about 28% by suffocation, and about 15% were poisoning, 6% for all other methods. So on average, every year we have approximately 11 firearm suicide deaths, about 6 suffocation, and about 3 poisoning suicide deaths. Okay, so here we're taking a look at age group and method. So I've divided out the age groups on the left, mostly by decade. On the right column there, I've put both the raw numbers and in parentheses, the rate per 100,000 for that age group. So looking at our youngest age group, the pediatric group, 10 to 17, they had a total of 9 suicide fatalities. 1 was poisoning with a rate of 4. Looking at the raw numbers, you can see that the highest numbers were those in their 40s and 50s. Both groups had over 50. But if you look at the rates, it's kind of interesting. We start off at the lowest rate, the pediatric group at 4. It begins to increase. It peaks at 40 to 49 at 20.6, and then begins to decrease until the 80 plus age group, where it spikes again. So the 2 age groups with the highest rates are those in their 40s and those 80 and older. Oh, another thing that kind of just struck me looking at this table are the poisoning fatalities. A total of 38. Almost half of them are in their 50s. Just something I noted. I don't really know what that means. All right, so some more on age. That top graph there, basically what I just showed you in the table, frequency graph, 40s and 50s have the highest numbers. The median age for fatalities was 48.5. The bottom graph here, we're looking at firearm versus non-firearm methods by age, and I just think this is really interesting. So the younger age groups, the under 18 and 18 to 39, use non-firearms, and the firearms are the light blue. They use non-firearm methods about twice as often as firearms. The middle age group there, 40 to 59, it's more evenly distributed. And the older age group, 60 plus, much more likely to use firearms. And now we'll take a look at by sex. So during this time frame, we had 201 males, 55 females. That's almost 80% male. And males are greater at every single age group, although a little bit more equivalent in the younger ages. And the median age of males is higher, 49 years versus 43 years for females. Okay, here's another graph I really like. This looks at sex and method. Again, firearms are the light blue bars. So for the top graph there, for the males, you can see by far they used firearms, followed by suffocation, and then third, poisoning. Whereas females, really no obvious preference among the 3 method categories. Maybe a few more poisonings. And just to look the specific breakouts in the table there, about 88% of all of the firearms were male, about 78% of the suffocation fatalities were male, about 81% of the other category was male. Only for poisoning is it more equal, 47% male. And I've just summarized a little bit with the bullet points. Suicide poisonings are evenly distributed between males and females, but all others are male dominant. More than half of male suicide deaths are firearm related, and females show no obvious method of preference.
That's actually surprising, the female piece, because I always thought that there's been data to support that females usually don't use methods where if somebody found them, they would be more gruesome. Like not look as good. So that's why I always.
The most violent option.
Right. That if somebody found them, it
I
would
think
be.
I heard that was not as, there was a time where they used less legal means, but I think I heard recently. I think Adam Lesser touched on a little bit. You know, it's kind
It's
of changing.
probably also at accessibility, right? We are talking about Carroll County and a lot of people have access to guns.
Okay, just taking a quick look by race. We've really only had a few non-white fatalities. Overwhelmingly 96% white and 75% have been white males. Okay, so here I've mapped rates by zip code. Just note that the county rate during this time was 12.3 per 100,000. And the zip codes that are the dark orange or red are those with higher than average rate. And also note that almost every single zip code has had at least one fatality. Okay, I know that was a lot of data. So to summarize that, our number of deaths ranges between 15 to 30 a year. Firearms account for about 50% of suicide deaths. The highest number are in those in their 40s and 50s. Highest death rates in their 40s and 80 plus. The older ages are more likely to use firearms. 80% suicide deaths are male, 75% white male, and males are more likely than females to use firearms. I thought this group might want to zoom in on just the poisoning fatalities, which range between 1 to 7 per year with an average of 3. They account for 15% of all suicide deaths, and the majority were middle-aged, evenly distributed by sex. So that was the fatality data. Amy, should I keep going with the hospital visits or? Okay. Yeah, it's only a few slides. So we'll be taking a look at hospital visits for suicide attempts and intentional self-harm. This includes ideation. We'll be looking at both emergency department visits and inpatient visits. This data comes from the HSCRC as viewed on the CRISP Public Health Dashboard. So I pulled data from the last 5 years. You can see both were at a high in 2019 and declined for a couple of years before leveling out in 2022 and 2023. And in 2023, there were approximately 460 emergency department visits and approximately 400 inpatient visits. Okay, here we're looking at emergency department visits by age group and sex. If you look at the total male versus female, it's almost exactly 50-50. However, if you look at individual age groups, there's a lot of differences. The younger and the older age groups tend to be predominantly female, while the middle ages tend to be male.
Does this include like anybody that would come to the emergency room on their own and like brought by law enforcement under?
Yeah, anybody who, yeah. So here's the graph showing that data, especially striking, I think, for the youngest age group there. And here's the same analysis, but for inpatient visits. Very similar findings overall, pretty much 50-50 male-female for the entire population. But again, the younger and older ages are predominantly female. And here's that graph. You'll note the population, the inpatient population tends to be older than the emergency room visits. Okay, there we go. So to summarize that, the number of emergency department visits ranges between 450 to 600 a year. The number of inpatient visits range between 350 and 500. Both have decreased since 2019. The visits overall were even between males and females. However, more males at the younger and older ages. And I think that's all I have. Any questions?
I just have a question back to Susan's and others' questions. I know we were focusing on self-harm here for this, but I know that you all have done a lot of work with the hospital on data and connected with them to get some data. Can they provide behavioral health overall ED visits to you? Have we asked for that? Was that, I know there was a huge list we asked them for, but I don't know if that was one of them.
Yes. Do you mind if I answer? Yes, so we've actually been working with Lorna, and she's been providing us monthly data that's very helpful. It's also very dense. So Dr. Wack and Amy and I are actually going to be meeting with her. I think it's actually a week or two. I think it's the 17th or the 20th, so that she can take us through all of the data that she's providing, and we can figure out how to effectively interpret it to better direct our programming. It's been very helpful.
Yeah, I'm asking that because, you know, I think here with all of the efforts, you know, I think for substance abuse, we need to know that we've decreased, but just overall behavioral health, you know, the whole 9 yards, like have we seen a decrease in emergency department utilization? And that's the question everybody wants to ask all the time. And I can get public data, but I'd rather see our own internal data. So I was going to ask her, but if you're already working on her with that, I'm not going to bug her.
I was gonna say, Sharon, with the new ASO that's coming into play, we will be able to pull a lot more information about the public behavioral health system. Those that Medicaid than we've been able to do with this current ASO.
Okay.
So in 25, we should have some more data related to the behavioral health numbers.
Okay, thanks.
And before we move on, I did just want to provide a brief update of some of our coalitions and work groups. So I'll start with the Suicide Prevention Coalition and then talk about the work of a subgroup concerning firearms under that. So for our Suicide Prevention Coalition, at the last meeting, we were fortunate to have a number of key stakeholders present from different agencies. And so we did a strategic planning activity with everyone to identify local contributing factors to suicide for different age groups. And we're going to work with Amy to analyze that and let it help us direct our programming. We're in the process of developing a comprehensive strategic plan around suicide prevention that includes the work that the coalition will do, the work that our unit does, and then other work throughout the community, prevention, intervention, and postvention resources. And also we're implementing initiatives around safe medication storage as suicide prevention, not just to divert to avoid substance use, but also as suicide prevention. And we provide medication locking bags to the hospital and to CCYSB. We're also working with the Columbia Lighthouse Suicide Screening Protocol, getting that into the community. Mental health first aid. We have another suicide training, question, persuade, refer, that we have a number of staff trained in. And we're supporting the Sources of Strength evidence-based program with CCYSB, just for a couple of things. The subgroup that we've started about a year, maybe a year and a half ago, it's a firearm safety around suicide prevention subgroup, work group. We've met twice, and at the end of the second meeting, the next steps were for prevention to kind of collate appropriate options for communication, implementation, strategic planning, things like that. So we've been working diligently doing that. And actually next week, I believe, or the week after, we're meeting with Dr. Krafasi, who's a professor at Johns Hopkins Bloomberg School of Public Health, who specializes in effective suicide prevention firearm initiatives from a public health perspective. And so we'll complete collating all of that and likely have another meeting in October to discuss different potential initiatives, including communication initiatives. There's an MDH toolkit that could be useful, and we're exploring a Virginia program that combines language with safe storage for suicide and firearms both. So there'll be a lot of different options that we'll present to that group that they can then select the most appropriate one for the county.
We had our first meeting, and when we started looking at the data, we all kind of took a step back when we saw the data on the older population and the use of firearms and suicide. So we kind of thought we wanted to do a deeper dive into the data to make sure that, you know, I believe Amy went over to the sheriff's office and looked at the data that he had and pulled some things from there and tried to get a better understanding of what that data was telling us so that we come up with the right plan if we're pushing something forward on gun safety. And that's, we just, you know, I don't care if everybody in Carroll County wants to have a gun in their house. I just want to make sure it's stored someplace safely, has a lock on it, and that kids don't have availability to it. And apparently maybe we need to do some targeted messaging to the older population, or find some resources for the older population that they feel that they need to use that as a method.
Yeah. And Amy, did you want to talk a little bit about your visits?
Or the other thing, Sue, one other thing too, families, we have more and more families with vulnerable adults in the home. So, education on locking your gun up, not just keeping it away from your kids, but your vulnerable adult that you're taking care of that, could be confused and such. We have seen some sad situations with gun use.
Yeah, just as Sue and Amy mentioned, yeah, I have been reviewing the data at the sheriff's office, all suicides, all those ruled suicides, and trying to pull out risk factors and other information that might help us. Been there about 3 times, still ongoing. I don't even have total review.
It's just one of those, after the first set, I think we all decided that's why that meeting stayed very small when we first started, and I'm sure we'll get larger once we have all the data that we can present to a group and say, what's the path forward from here now that we know what we're looking at.
Yes, but the data collection process is lengthy and with good reason, so we can direct resources in the appropriate direction.
We don't have the type of, and that was exactly what law enforcement said that came to that preliminary meeting was, we don't have the violence and the crime with the guns like you have in the city and some of the more populous areas. But what we do have is concerning to us, and we've got to figure out what's the proper messaging and how do we get that into the homes of people.
Sue, additionally, I will add that I just learned last week that LifeBridge Health in total is doing a whole big thing through Center for Hope on prevention of gun violence in general, whether that's suicide or street violence or all kinds of things. So would love to partner with you on that.
Very good.
Still help for we closing.
Yes.
I don't know. It says risky business slide note.
I think that's all.
We needed to do. Okay.
I think we're all good.
All right.
Okay.
And wire BS data.
It's preliminary. No, it's not. I think it's all still embargoed.
All right. So I need a motion to close the. I'm gonna get it wrong, so I'm gonna look at the top. The overdose prevention policy group portion of the meeting.
Motion.
Thank you. Second. And now I need a motion to start the rehab meeting.
So we're gonna go through.
I make a motion to start.
Now, or I can do it later. So I'm gonna share the.
Second. Liz, thank you. All right. And I don't have it shared today, so Kathy and Marie and Amy.
Yes.
Are gonna cover for, Stephanie has a personal crisis she's taking care of, and, we did get the information ahead of time. But, this last time I asked her person that was covering for her, she was going to be my co-chair. She looked at me like, with wild eyes, like, nope, I'm just covering the meeting for her.
I tried that today too, and I got it wrong. Anyway, well, thank you all for staying on the call. I know we're getting short in time. I just wanted to give everybody an update. We just updated our Carroll County Health Department website, which means all of our behavioral health links and those kinds of things have changed a little bit. Amy's going to manipulate the computer. As you can see, there's administrative services, behavioral health services. We, of course, fall under the behavioral health tab. I'm going to open that.
Oh, wait a minute. Can you scroll back up so that I can make sure anything you see that has the Maryland flag emblem on it, if you click anything in there, you're going to go to the Maryland Department of Health. So you want to wait until you get down to the blue. That's the delineation that you're on the Carroll County Health Department's website.
Scroll down. Yeah. So, tabs.
They're on the side of the.
Up,
Down.
down.
Okay. I'm frozen.
Oh.
Up or down?
There they are.
Do you want me to just hover here?
No, she wants you to
I
go
want you to go
purple
down,
things
so
on
I'm
it.
going to show the app all the way down. There you go. Look. So as you can see, some of the tabs are listed out: behavioral health services, crisis intervention, eSmart, Keep Talking Carol, law enforcement assisted diversion, lead, and the behavioral health authority. So open, and there's more. Mental health first aid, mobile crisis, naloxone training. Keep going. PATH, which is our support for people experiencing homelessness, our peer recovery support and our reentry services, our state peer coordination, which is assistance for those being discharged from residential substance use, prevention services is listed, and tobacco, nicotine, and vaping cessation. So all of those links, let me just open one of you, we have prevention while you're in it. Have tabs in addition, and how to get services, and keep talking Carol. Open one of your tabs. And then there's some additional resources under each one of those. So it's pretty in-depth. If there's something missing as you view it that you think we should add, please let us know. The Behavioral Health Resource Directory is in there as well. So it's pretty good material. I think it was well done, and thanking Maggie and Rachel from the health department because they did a great job with it. But there's other like environmental health services is in here, cancer services. So if you're working with any potential clients that could use any of the health department's resources, this is your go-to. So, okay. And I'm going to turn the meeting over to Marie, who's going to give some local behavioral health updates and some BHA updates.
Thank you. Actually, we got quite a bit of updates. Not a lot about everything, but a little bit about something. So, first thing is, I don't know if anyone know that Comar is in draft again for treatment facilities, and it's currently draft. BHA has given their comments, but we are waiting for approval. I'm sorry, I'm looking at the screen so the people in the room that is so rude there. Trying to keep it right. So be on the lookout for that, for what that's going to look like for us, and then what that means for the community as well as the treatment providers.
Marie, can I ask a question about
Sure,
that?
yeah.
So I'm just wondering about the effective date of the new regulations.
I have no clue.
Okay.
Yeah, it's still in draft.
And does anybody know if there's anything coming about in terms of like the size of treatment space and like the actual logistics of that, or is it other things that are changing?
A lot of it was the language being used, changing some of the language. Some of it was some of the more oversight that the LBHA was going to have on some of these treatments.
There's a lot more regulations regarding the residential services
Yes.
than there is with outpatient services.
So when they redid the regs last time, they didn't really redo them.
No.
They really got rid of the regulations and they were using accreditation. What they've learned is each accrediting body has their own standard, and there's no real standardization of, it used to be, I knew that beds had to be 3 foot apart, you couldn't be more than 18 inches close to a heat register, and yada, yada, yada. And they took all of that out, and what they found was they took too much out. So there will be things put back in about residential facilities. Because they're finding that there's too many beds in a room, there's not enough living space, or there's not, I don't remember, I think these 2 dresser drawers, they used to have space for the clothing, and it used to define that. I think that one of the things they were trying to accomplish by this was to put some of that back into regulation, because they found that the accrediting bodies really weren't looking at those things, and they were getting complaints, and there was no way to enforce it because we didn't know what the accrediting body had said. And speaking as somebody who was an LDHA at one point, you had to know all the regulations for JAGO or CARF or the National Accreditation Council, and all of them are different, and you have to pay for all those books. So it's like, there's no way to enforce it. From our point of view, that was not something we were empowered to do. That's something the state wants the locals to do, is go in and actually look at these residential programs and make sure that, you know, they're fit to live in. And that the people are getting the space that they need. So that's why they're not part of this. And the other part of this is to define your role as the LDHA more clearly, because when they merged all of that together and made everybody a local behavioral health authority or CSA and LAA together, there wasn't a lot of continuity.
Yeah, if you like, so it says if you see one health department, you see one health department. It's the same thing with LBHA. You see one LBHA, you see one LBHA. different things work for different jurisdictions for their communities. So, yeah.
Do you know the crisis stabilization is also in the certificate update? Or is that a separate?
I think that's under the
Separate,
crisis
yeah.
regulations.
Okay,
Which aren't finalized. I don't.
all right.
More to come. So Kathy and I actually just left a meeting today in Gainesville with the Bureau of Administration, and it was the first in-person meeting in quite some time for the director. So it was very informative. There's also a virtual option, so some other people attended, but some of the stuff that was covered was, and this is no surprise to anybody, with the budget reductions throughout the state is also going to affect at the level of the Bureau of Administration, which then affects programming. So FY26 is going to look pretty thin, which we're not surprised about because we're already feeling that in FY25 as well. So when they're looking at the programs, they're going to be looking more at your service delivery and the outcomes. They want to know what's being done and what's the final result. Are the programs you're implementing working? So we're going to be doing a lot of our reporting is going to be just that, about outcomes measures. It's going to be looking at more geographic data. It's going to be looking at what is defined as successful, beneficial. So we're going to be tightening up a lot of our reporting. And BHA has moved to a lot of different reporting as far as we have now these universal reportings that we have to do quarterly. So just more to come on that and how that might affect some of our service delivery and what we're asking for from our providers as far as the outcomes based. Speaking about the AOT, the Assisted Outpatient Treatment Programs, has anybody heard of that? That's mandated outpatient treatment for individuals who have severe psychotic mental health diagnoses who are committing crimes. So there was an evaluation done for the state of Maryland, and for the state of Maryland, they found through comparing hospitalizations and authorizations through Optum and also through crimes committed, that 600 to 700 individuals would have been a successful candidate for AOT. And in Carroll County, we would have had 14 participants that would have been eligible. So this is something moving forward that the city's saying we're going to have to do. So more to come on that. There's a pilot being done throughout the state, and I believe it's starting in Wycomico County. So just more to come because we will be having conversations about what that's going to look like in our county and what is required to stand up in AOT. So more to come.
And just recently, we've had an individual that would have benefited from this level of care. He was causing a little bit of havoc in the community.
If anyone is not aware, Optum, our ASO for behavioral health, is going to be changing. There was an RFP that went out, not last year or the year before, but a vendor was selected. It's Carillon. They're going to begin services January 1 of 2025. They've actually already started working. So they're working on stuff on the back end before they actually start taking over to do the authorizations and so forth. Like Kathy said, we will have more access to data, which is great. Providers will have one place they have to go to for all their stuff instead of a bunch of different places. So Carillon is putting on provider forums. They're doing it jurisdictionally because they're hosting it in person as well as a virtual option. So I did attend a virtual option, I think it was last month, but I can send out the 3 other options that are available for the year. They're trying to do them every 12 weeks. So that's once every 3 months, once a quarter. It was very, very informative. So I would recommend attending. Our crisis services. So crisis services put out an RFP last year, and they are starting 19 new pilot programs in the state. They're going to be meeting with 6 of the jurisdictions that did not apply for this funding and work with the LBHAs to really look at our crisis system delivery and what we can do to improve that and what gaps and barriers we may have. So more to come on that. We'll be one of the jurisdictions meeting with them. Zoning. Let's talk a little about zoning. So Carroll County, we're getting a lot of providers coming in who are wanting to open up our the 3.1 levels of care, which is your residential treatment, your what used to be considered an old halfway house, but is now a level of care that is billable through Medicaid. So we're seeing a lot of providers coming into the county that are requesting to open up these services. So in Westminster City, we made sure that if somebody applied to have an agreement to cooperate to open up that service, that they were in contact with zoning because of all the zoning issues going on with having people that are unrelated living in the same home. So county zoning asked to have a meeting with me to talk about some of the facilities they're seeing in the county that they needed to find out, is this a recovered residence? Who lives here? Is this assisted living? Is this a level of care? So I had a meeting with them probably 2 weeks ago. I was on vacation last week, so 2 weeks ago. And they are asking also that when we find out that somebody wants to open a 3.1 or a recovered residence or a sober home, even though we have no jurisdictional oversight of any uncertified recovery residence or sober home, if we know about it or anybody's coming to us to be a certified recovery residence or a 3.1, the county zoning would want a heads up on that as well. So just FYI, I'm letting everybody know that to be transparent. Because there is a lot of confusion. They're getting calls for people wanting to open up places and they're like, well, what is this? How many people? Who licenses this? And I said, well, nobody licenses that. Well, what do you mean? Well, it's an uncertified recovery. Nobody licenses that. So I just wanted to let everybody know about that too, to be transparent. Any questions about any of that before? The last thing that I have on my agenda is the triage and crisis beds. So I do want to let everybody know we applied for funding for continuation of the residential crisis beds, which are triage beds, down at the Buttercup location for Mountain Manor, Sykesville. SOAR 4 was approved. It is approved at a reduced amount, but I still think we're going to be okay to cover because we also have our non-opioid money, which services individuals who do not have that opioid stimulant diagnosis who can still be treated. So that new SOAR 4 begins on September 30th, and then we'll run through the federal fiscal year again through September 29th. So that's really good news. And then any questions about any of that before we go to provider updates?
Great. This is Celine online. I did have one question. Did we communicate that amount and let budget here at the county know about the SOAR approval?
That's a really good question. I know I reached out to Mayor Sykesville and I've been in touch with Bill Roby and Megan Westwood. And I've been in touch to get a new contract signed, but I'm not sure that I did that, Celine. So thank you. I thought I put it in an email where I sent you the triage bed census.
Right, but if she wasn't on, I just want to make sure that got sent along. Okay.
Okay, I will do that. I will do that today, actually.
Thank you.
You're welcome.
Before we do provider updates, I just want to add that I know that most people saw that the state of Maryland reduced funding to all the local health departments for public health services. But in addition to that, the LDHA did take a hit of about $120,000. It was in harm reduction. It is not going to impact any of the services that we had planned. We've just had to move some things around. So they will not have, I think it's a coordinator that they were going to hire. But we're still moving forward with all of the harm reduction efforts that we had proposed for this year. The health department overall is moving some other things around and making use of some new money that came in to keep us afloat this year. And, you know, we've been asked to provide some information on what the impact will be next year because we were already in this fiscal year when that cut came. So it wasn't like we could go back and say, well, we're not going to do these things now because we already had plans to do them. So we've managed to figure out ways. We have a couple of vacancies we're not going to be filling. Unfortunately for us, there are some very important vacancies coming up, like, you know, contracting and HR and timekeeping, which we do not have the luxury of not filling. So we're being very careful on what positions we're filling and how we're filling them this year. So at this point, there is no nobody losing their job and no reduction in services. as it stands at this moment. So, but CAP is, as far as the LBHA, they took $120,000 loss. Health Department took about a $500,000 loss. So it's a considerable chunk of our budget that was reduced.
Yeah, BHA actually took a pretty good hit as well. If I wrote down the number sheets, I originally thought I did. I took some notes from this meeting. But they took a substantial amount as well in reduction. $149 million reduction for FY25 is what the Hero Administration took.
Public health was 150.
Yeah.
$150 million cut.
Yeah.
It was a big cut to services. So.
And FY26.
The transportation authority is on the next, cut, 1.6 million, something like that. It's a good portion of their budget. So, that's where we stand right now. More to come. We have applied for some other funding. We're making use of some other funding. The CDC has come out with some public health infrastructure money that originally was targeted for certain things, but now they're offering some additional money towards accreditation and some other projects we were in the middle of working on. So we're trying to avail ourselves of that funding and then free up other money that we can put back into the people and the resources so that the consumers in the community don't miss out on what they need.
I do want to add one other thing too, that while we were at the meeting today, there is a suicide prevention conference that the Behavioral Health Administration is putting on. They're setting out, they said the press release just released today, but it's October 2nd. So we will be sure to forward that information out if anybody wants to register for that. I do believe it's virtual this year, but just letting you know. Any other questions?
Anybody has anything they want to share?
The sergeant was here who had stuff he needed to share.
He just.
I wonder if he usually was here. Please tell me that. Oh, okay. Oh, shoot. I know he had some updates he wanted to share.
No.
Yeah, he had his pager.
Yeah, Sergeant.
Okay.
Yeah, I'm sorry.
Anybody on the screen?
Just a reminder, our Seniors on the Go Expo, which is now Aging Your Way Expo, is on the 12th of September. Many of you will have vendor tables there. And we'll also be joining the other folks for Priority Carol with your suicide prevention and your recovery month Priority Carol tomorrow morning. So we'll be promoting our expo there. So hopefully we'll see everybody there and we can all get together on our promotions of these events for this month.
We'll see you tomorrow.
I also wanted to add, so we're going to be partnering with the Bureau of Solid Waste Management again. We're holding another Take Back event on Saturday, October 19th from 8 a.m. to noon. It will take place again at County Maintenance. So we'll be taking back meds, sharps, vape liquids, and CCG doing, and the Carroll County government will also be doing household hazardous waste and shredding as well.
Then I just need a motion to close the meeting.
I'll motion that too.
Second. I'll second. All right.
Thank you.
Got you out a little early. Give you some time back. But thank you all. If there's anything you want to see in future meetings or data you want to know about, please let us know.
And Kathy, if anyone wants any of the 988, just send me teresa.moyer@maryland.gov and we can send that to you. Or people picking up, or you can pick up.
Whatever you want.
Bags and clips. And Maria, I don't know what these are.
Those are the things on the back of your cell phone, like is it a fidget popper or something?
Yeah, pop it.
Okay,
Yeah.
I have some of those here. So if anyone wants anything. Anyone here can take as much as you want.
Make sure you're back.
Hi, everyone.
Bye.
Thanks for joining virtually.
Did that.